Well, welcome everybody. Thank you so much for joining us for our Data to Drive Decisions today. Our topic today is using data to reduce low value care. Thanks again for being here. My name is Carrie Frank. I am the Vice President of Communication and Marketing here at CIVHC, and we are joined by two fantastic presenters today. We have Kyle Russell from Virginia Health Information. He's the CEO there, and he's going to speak about what Virginia has been up to for quite a while, addressing low value care. And then I also am joined by my colleague, Tim Janader. He is a healthcare data analyst with CIVHC, and he has been our lead analyst to conduct the low value care measure here in Colorado for the last several years. So really excited about our presentation today. Just a few little housekeeping items. We do have you all on mute, but we are very excited to interact with you today. So please, if you think of questions, feel free to type them at any point in time into our chat box today, and I will either address them immediately if it's something that we need to clarify, or we might save it till the end. We will have a formal Q&A session at the end. We'll save about 10 minutes at the end for Q&A, but feel free to type in your chat messages at any point in time. And the other thing is we wanted to make sure you're all aware it is being recorded. We are going to share the slides and the recording with you after the fact. So no need to take vigorous notes. You'll be able to refer to everything later. Just a little bit about CIVHC in case you are joining our webinar for the first time and you haven't interacted with us. Our mission is to empower individuals, communities, and organizations. And what we do is provide support services and healthcare data and information to advance the triple aim of better health, better care, and lower costs. So everything that we do strives to address the triple aim. We are a nonprofit organization, 501c3. So we pride ourselves on being independent and objective in our work. We do serve a wide variety of stakeholders, and we call them change agents. And those are folks boots on the ground or individuals, consumers, all are in the middle of that circle that we have. So we work with clinicians and physicians, hospitals, employer groups, government agencies and state agencies, researchers, nonprofits, health plans. Those are all the folks that actually have their hands in healthcare. But everything that we do is really to lower costs, improve care, and make the consumer, the Coloradan, all Coloradans healthier. So today we're going to be talking about data that is in the Colorado All-Payer Claims Database and the Virginia All-Payer Claims Database. So just a little background on what we have in the COE PCD. We have over 870 million claims at this point in time. That's through 2021, even though we have data into 2022. This is a snapshot of calendar year through 2021. We do go back to 2013. And so if you added in all of those claims, actually we go back to 2012. So even adding the 2012 claims, we'd have even more. It's a little easier to talk about what we have on a calendar basis. We have 36 commercial payers plus Medicare and Medicaid. And we get Medicare Advantage and fee-for-service. That equates to about over 5 million lives in Colorado annually, including about 1.5 million of the self-insured employer lives. We don't collect all of those on a mandated basis, but they are voluntarily submitted. And that represents about 70% of the covered lives here in Colorado when you're looking at just medical coverage. And again, we have trend information across all of those years. So it's a robust data set. We turn that information into both public data as well as non-public data. So we have a whole slew of public information. The low value care information that we're going to be sharing with you today is all publicly available through our affordability dashboard. So if you're interested in interacting with the data, you can go to our website at civhc.org and get under the Get Data tab, you'll find all of our public data. We also provide non-public data to a variety of change agents, and those are in the form of data sets and reports. And Tim will be talking to you about what you might be able to get from the low value care data, specifically on a non-public basis. So I am going to turn it over to Tim now to share his wisdom and talk to you all about what we've done here in Colorado so far. So take it away, Tim.
Great. Thanks, Carrie. So I'm going to give an overview, discuss CIVHC's analysis of low-value care using the Colorado APCD data. So CIVHC engaged Milliman to apply version 8 of their health waste calculator to the Colorado APCD to measure the use and cost of low-value care services. This current report summarizes the analysis for 58 measures of low-value care from 2017 through 2020. A previous report issued in 2020 used claims data from 2015 through 2017. That report was based on version 7 of the health waste calculator, so results are similar but not directly comparable. And then in the future, CIVHC plans to update this, sending data to Milliman on a semi-annual basis to continue looking at trends in low-value care through the future. So let's start by defining what is low-value care. So in 2012, the American Board of the Internal Medicine Foundation launched what's called the Choosing Wisely campaign, asking medical specialty societies to identify tests or procedures commonly used in their fields whose necessity should be questioned. Today, there are more than 550 Choosing Wisely guidelines. Most of Milliman's measures were derived from Choosing Wisely, and all of the ones we have can be derived using claims data. So a survey of physicians suggests that several factors contribute to the delivery of low-value care. These include defensive medicine due to fear of malpractice, perceptions that patients want or expect diagnostic tests or medications, lack of information regarding a patient's medical history or inadequate time to spend with a patient, and finally, financial incentives or financial conflicts of interests. So here are 4 examples of the 58 measures included in this analysis. So pediatric head CT scans is one of them. They're considered low value because they have a low diagnostic yield and high potential risk of radiation and associated cancer risks. Imaging tests for eye disease is unnecessary for patients without symptoms or signs of significant disease pathology, because comprehensive history and physical examination will usually reveal if the eye disease is present or getting worse. Another one is cardiac stress testing. This and other advanced non-invasive imaging in the initial evaluation of patients without cardiac symptoms is unnecessary and wasteful unless high-risk markers are present. And finally, another one is routine general health checks. So for asymptomatic adults without a chronic medical condition or other health concern, the Choosing Wisely guidelines say that routine general health checks with a comprehensive physical exam and lab testing is unnecessary. Now, we recognize that this measure in particular is controversial, as many believe that maintaining a relationship with the provider is necessary for general good health. However, it is a Choosing Wisely recommendation and therefore is included in this analysis. So a 2019 study published in the Journal of the American Medical Association estimated that 25% of healthcare spending, or approximately $935 billion, is wasteful, and much of this waste is due to low-value care. The reduction of low-value care is appealing because it can lead to both cost savings and improvements in quality of care. All right, so now I'll walk through some of the key points on how we use this data and our reporting methods. So to begin with, only patients with sufficient claim history to accurately determine wastefulness are included. Also, these 58 measures are classified into 3 degrees of patient harm. There's low, medium, or high, depending on their long-term effects or propensity for cascading medical events. Also, services are grouped into 4 categories. There's wasteful, likely wasteful, necessary, and optimal. Likely wasteful and wasteful are both considered low-value care. Necessary services mean that a low-value care service was identified, but the care was clinically appropriate and therefore not low value. And optimal services are those administered in accordance with the best practice guidelines. All right. Throughout this analysis, low-value care is reported in several key statistics. You move to the next slide, Carrie. The low value index is the percentage of low value care services out of the total services identified as potentially low value. The optimal index is the percentage of optimal events out of the total services measured. The percent of low value costs is the percentage of costs for low value services out of the total costs for services identified as potentially low value. And finally, cost per member per month is the cost of low value services divided by the total months of insurance enrollment for the specified population. All right, now let's get into some of the actual results. So this slide shows summary results, statewide trends from 2017 through 2020. And we see in these graphs that the trend for both spending and volume of low value care has decreased over this time frame. So in 2017, spending for services triggered as potentially low value was $1.85 billion, of which 11.2% was considered low value. By 2020, this rate had decreased to 9.9%. The number of low value services decreased from 2.2 million in 2017 to 1.8 million in 2020. And the low value index decreased from 43.4% to 39.7%. The cost per member per month for low value care also decreased from $4.63 in 2017 to $4.09 in 2020. And as would be expected, as low value care services and spending decreased, the number of optimal services increased. From 2017 through 2020, the optimal index increased from 76.8% to 77.5%. All right, from here on, we will be looking at results specific to 2019, as it is the latest data available not affected by the coronavirus pandemic. So when we look at results by insurance type, we see that spending for low value services was lowest in the Medicaid population. However, Medicaid did not have the lowest volume of services. This can be explained by Medicaid having a significantly lower average cost per service at $78 than the other populations. The average cost per service in the commercial population was $100, and it was $115 in the Medicare population. When looking at low value spending as a percentage of all spending, the Medicaid population was the greatest at 12%, while commercial insurers had the lowest at 8%. Even though the commercial and Medicaid populations have a higher volume of low value services, these services are spread over a larger member population. The Medicare populations have much greater population-based rates, indicating that the delivery of low value care services was concentrated in a smaller member population. All right, next slide. These maps here display low value care services and cost statistics in 2019 by geographic region using the 9 Colorado Division of Insurance rate setting regions of the member zip code at the time of service. So by looking at these maps, it's evident to see there are areas where low value care is more prevalent in both costs and services provided. And this provides an opportunity for focused action to reduce low value care in these specific areas. All right, and here we have the most prominent low value services. So in 2019, 17 services, the 17 listed here, accounted for over 90% of both the total services and spending of low value care. They are shown here in descending order of total spending. It is interesting to note that the 2 most costly services, inappropriate opioid prescriptions and the concurrent use of 2 or more antipsychotic medications, are both based on prescription medications. Also of note is that this list includes services with a wide range of costs per service. This illustrates that wasteful spending is not only a problem of the unnecessary use of expensive tests and procedures, but also an excessive use of unnecessary low-cost services. 4 of these services have a high degree of harm to patients, including 2 of the top 3. 7 services have a medium degree of harm, while 6 have a low degree of harm. All right. As part of CIVHC's mission to improve healthcare through better services and lower costs, this low-value care information is available, as Carrie stated, as a public report on the CIVHC website's affordability dashboard. We have also and can also parse this data out by employer groups or provider groups to provide resources in the mission to reduce low-value care. So ultimately, the goal is the reduction of low-value care. And we at CIVHC plan to engage providers and payers to share where low-value care is an issue and hope to see tangible results in the near future. And as stated before, we plan to continually update these reports on a semi-annual basis to track the changes to low-value care throughout the future. Thank you.
Thank you so much, Tim. Yes, and as a reminder, Steph or Spencer, can one of you put in the chat box the link to the affordability dashboard so folks can see where to go to interact with this data? Because as we went through quickly, there's also some infographics and some other things on our website, but you can look by those regions and see what the top low value care services are in those regions. And it is very different when you sort by region and by the type of payer as well. So thank you, Tim, for all your work on this and for sharing your expertise in the results. Thanks, Steph, for putting that in the chat box. And I'm going to turn it over now to Kyle. They've been at this a lot longer than us, and they're doing some cool things with their low value care project in Virginia. So we're excited to have you share. Thanks, Kyle, for being here.
Yeah, sure. Thanks, Carrie, and thanks for the invite to get to speak with you all today. Just to kind of wrap up on Tim's slides, though, the last slide you had, or that last graph that showed all the different measures and then the cost per prescription, that was about as concise as I've seen that information displayed. So I might I'll change the colors, but I might have to steal that from Virginia because I really like that. I saw the slides in advance. It never sort of resonated with me until
Steal shamelessly. We'll probably steal stuff from you. So right back at you.
So as Carrie said, we've been reporting on low value care in Virginia for a while. And we were talking about that a little bit before the webinar started. I was like, oh my gosh, it has been a really long time that we've been at this. And so I think my objective today is to kind of walk you through that journey that we've had, like the ups and downs and how we got started and kind of some of the big monumental events where we are now. So Carrie, if you want to go to the next slide. And so I'll start as like where things were when we first started doing this, when this was kind of a twinkle in our eye back in 2014, 2015. There's a lot of scrutiny on APCDs, right? I mean, Colorado has always been really good about making sure that they use their APCD for all kinds of different reporting, but some of the rest of us were getting slammed on a bit for not using the systems enough that had been built to that point. And then also too, choosing wisely was relatively new, and it was a little uncertain how much traction it was going to gain with physicians at that point. Versus if you go to the next slide, let's say 6 years later in Virginia, we've got over $2 million. We got multi-million-dollar grant to operationalize and actually try to go do interventions based on the reporting that we did. That spans thousands of physicians and over 1,000 practices all working together to put this data to work to reduce low value care and some of the select metrics that we're reporting just the same way Colorado is. So it really came a long way during that time frame. And so if we go to the next slide, I mean, I think the agenda for today, not too many surprises here. I'll talk about who VHI is, and spoiler, we have a lot of similarities with CIVHC. And then really just what our journey is, like how we started with reporting all the way up to Smarter Care Virginia, like that being kind of the culmination, that we're actually almost done with that intervention period, which is hard to believe. And then just a little bit of reflection on lessons learned that we've had along the way that I think are very applicable to all kinds of different states and regions and territories that are going on their own path towards expanding their low value care reporting and intervention. So if we go to the next slide, for VHI, so similar to CIVHC, we're independent 501c3. We've been around since 1993, and we administer Virginia's healthcare data collection laws, exchange, and reporting. And so very similar to we were intended to be this unbiased independent entity that sits in the middle and has equal representation from all parties on our board to make sure we're serving the sort of data collection, reporting needs, plans, providers, Republicans, Democrats, you name it. Everyone needs to be represented and have a seat at the table. And so if we go to the next slide, so you can go on our website and see, like, I can't even tell you exactly verbatim what our mission is. It's a little bit wordy, but kind of how I boil it down here. We're breaking down walls and opening channels to share healthcare data. Simultaneous to that, we're supporting reporting where transparency is needed the most, and low value care certainly qualifies for that. And then, as I mentioned, kind of in our organizational structure, we have to do this in a way that's unbiased, collaborative, and provide substantial return on investment to the Commonwealth per dollar of investment. And that could be being able to do things at a low cost. It could be the inherent value of what the data that we're democratizing. There's a lot of ways to go about that, but we always want to make sure that we're providing that really strong value proposition to all of our constituents in the Commonwealth of Virginia. So how that's evolved over time, I mentioned we've started all the way back in '93. We were set up to just do one program, and that was the hospital, what we call the hospital discharge database in Virginia. And that was our pride and joy for a really long time. Then, you know, the next monumental event, 2013, we were, I think, I forget what year Colorado was. I think you were all maybe a little bit ahead of us. We were about the same time frame, maybe. We set up the all 2012. All right. So yeah, we and I think our original layout is actually based on you all's too. So thanks for that. But in 2013, the all payer claims database was established in Virginia. And that's actually, it's like what I was hired to do was to work on the APCD when it first started. So that's always had a special place in my heart. And then more recently, the expansion areas have been around health information exchange. So we became the state's official health information exchange for the past several years. And that is quite the resource hog and is taking up a lot of our energy, but we still put a lot back into the programs that we've accumulated over the past 30 years. Next year will be 30 years. So if we go to the next slide, I mean, really our focus today though is on APCD, and there really shouldn't be any surprises here and who submits and what we get. I mean, it's kind of like, it's very similar. I think Colorado is doing a little bit better job of in the ERISA department. I don't think we're at 50% ERISA in Virginia or anywhere close to that, but pretty much all the other sources that we can get, we have. And I think it nets out to, right now with Medicaid being a little bit higher, I think we're about 6 million individuals and a state population of about 8.5. So if we go to the next slide. So one thing I want to make sure to call out here is our partners in crime for all things low value care. And frankly, VCHI is kind of the poster child. I mean, they're the lead for low value care in Virginia. And then we are their supporting partner to make sure that all the data that is needed and reporting and kind of anything that we can do to support them and support all the other organizations that have a vested interest in this have what they need. But this is definitely not just a VHI show. This is a partnership between VCHI and VHI. That has worked out really well over the past several years. So we go to the next slide. So this is kind of how it all started. So back in 2013, 14 range, CMS had these, it was SIM grants, it was state innovation model grants. And Virginia got one, and VCHI was the organization that got it. And one of the different things they wanted to use that money for was this unheard of thing about reporting the low value care. And it just so happened that our vendor for the APCD, Milliman Med Insight, had this new tool called the Health Waste Calculator. Now, I'll tell you, not everyone loves that name, and they certainly didn't love it then. But they said, if we took that tool and we ran data through this new system called the All Payer Claims Database, like that's pretty innovative. New data, new software, like let's see what that looks like and really socialize that now that we've got kind of some funding to get this thing started through the grant. So we partnered together and we didn't really know what we were doing. And we said, all right, yeah, sure, let's do it. Let's run this new thing on the data. And I was talking about this a little bit earlier. We put out this report that this is the screenshot of the front, the Virginia APCD Med Insight Health Waste Calculator initial results. This thing was like 120 pages. And it was like, we printed it and it was just page of just these printed Excel tables. It was absolutely hideous. It was the least accessible report. The formatting was just like that thing was a beast. But what happened was that the people were so interested in the concept of reporting on low value care and so interested in what the results were, they didn't care. They overlooked this terrible formatted report and said, we actually want to, not only like, are we not going to know this, we actually want to read and look through all these different things. And, Carrie, if you want to just keep hitting the sign here, so we want you to do it again. And we didn't really learn our lesson. We said, all right, well, you know what? Let's give you another 100-page report the next year. Maybe the third year we'll cut it down to 50 pages. And so as you can see, we're not going to win a beauty contest, but these reports were such a big hit, like particularly when we're trying to get the ABCD off the ground, nothing generated interest like these reports. It was so engaging. Now, it was also a little controversial, so not all the attention was positive, but at that point, I think we would take what we could get with it. And so kind of how we did that, year after year was like our annual report of, low value care, and it was this big release. And to give you kind of how the scale was back then, like 2018, we're hitting like $539 million unnecessary services potentially. Now, some of the versions have changed. I think the number would actually be a little bit less now with some recent innovations, but that was a really big number. I mean, it still is. And that garnered a lot of interest, right? When you're reporting and saying, hey, it's kind of like in the old days, like and maybe people still do that. You could clean up your computer and hit that button, and it would get all the junk off your computer and it would make that flushing sound. It was a little bit like seeing, it's like, oh my gosh, there's all this money out there that we could potentially save if we did something about these results. So go to the next line. Then the subsequent requests started coming in and say, all right, well, that's cool. That's what it looks like for the state or for the region. But then everyone wanted to know, like, well, what does that look like for me? Like, what are my low value reports look like? Like if we're 500 million statewide, like, do I have a couple million in low value services I could potentially cut out? Because I would love to have a couple $1 million back in my budget, believe me. So with this, I don't put this on here like officially, but we did a series of reports for our Commonwealth of Virginia employees, and they love these reports, and we still do these for them to this day. And we would get requests from individual health plans, from our Medicaid agency, like everyone kind of know, like, what does that look like for us? Like, what does our slice of the pie look like? And so if you go to the next slide, we kept getting, additional requests. And then we actually started to do a research project and do a deep dive into how the results had trended over time and what they looked like. We partnered with UCLA, John Maffei, prominent medical researcher out there, who was this kind of sort of budding expert and prominent person in low value care. He said, well, let's look at the Virginia results. And he put his analysis together. He submitted it to Health Affairs. Health Affairs picked it up, and it got published in, I believe, October. I'm going to have to, I can't remember if I put it on the slide here now. It was 2017, released in October. Only 3 months for that year, it was the third most read article for Health Affairs online for the whole year in just 3 months. So we should have released it earlier in the year, but man, it got so much attention from doing a deep dive into these results. And that's kind of where it went from just being a Virginia thing, in our mind, to being a lot more of a national reporting ideal. So if we go to the next slide, that's where things really started to pick up after that. This got the attention of different funders. And so VCHI went to the Arnold Foundation and said, hey, I bet if you look at these results, I bet if we did an intervention program to try to target a few, we don't want to do all 48, but if we did a subset and we targeted some of those different measures, I bet we could save a lot of money and honestly cut out potentially harmful services for patients. Like if you could make an investment, then we'll put the program together and we'll provide all kinds of information to the different participants. And the Arnold Foundation, the credit said, you know what? Yes, that is worth a hefty investment. We want you to take the lead and be a pilot site to see what it looks like to actually try to do something with providers around low value care. So hence Smarter Care Virginia was formed. So if we go to the next slide. Now, I know this is predominantly Colorado audience. So you probably recognize HCA or some of those on here, but these are really big systems. Like these are their participants. Like I said, I wasn't kidding around when I said there's 7,000 physicians and over 1,000 practices. We got 6 of the largest systems in the Commonwealth, in all the different regions of the state, which vary quite a bit, to sign on to say, you know what? Yeah, we probably have some low value care we could cut out, and we want to be part of this intervention and work together to see what we can do to do a better job for our patients. So if we go to the next slide. So these are the measures I'm certainly not going to read them all to you, but just to say that there was 48 measures. As a group, everyone said, well, it's like 7 to 9 that we think we could do the most with. That if you got 40 measures, to be honest, right, it's like, does the provider really control all 40 of them? No, they don't. And so there's only really some that you should focus on in intervention. And that kind of depends on who your intervention's with. If you're doing a patient campaign, it might look a lot different. But these were the major categories of these different measures. And, as Tim showed before, they tend to, like, the full form name of these things tends to be described in a rule. And so obviously you don't want to not ever do pre-op testing. It's just within certain circumstances, it may not be the best idea for a patient. So just think about whether it makes sense in that specifically clinically nuanced circumstance or not. But these were the 9. And so our lofty goal has been to produce a 25% relative reduction in these services for all of our participating systems, which is a pretty big reduction, admittedly. So if we go to the next slide. So in terms of what we're doing, like as part of the intervention, so the big thing, right, is the data. We give all the systems benchmark reports on how all their physicians are doing, how they're doing overall, how they compare to statewide, regional, any customized benchmarks we want. We'll customize how they look for them, how we structure them, whatever they're interested in, we try to make life easy for them. But it's not just about the data. We've got all kinds of continuing education. There's faculty resources for experts in low value care that are signed on to be leaders on the project. There's monthly calls for systems to swap best practices on what they're doing, and maybe what others should consider that seem to be working or not working. There's a lot of talk about physician communication. That's a huge part of this. And there's also online resources for participants as well. So if we go to the next slide. So we've got, I've got slides up here with graphs and everything, and I'm not actually going to focus on any of the data at all. So if you can't read it, don't worry about it, because I'm not going to really point out any specific number on here. Just to say that, but I talked about how we customize these reports, and that has evolved over time, right? This report is like the base layer, like the go-to landing page for the systems, right? It's like, let me go in, how am I doing overall? And then I'm looking for, so some of the faculty involved in the programs, it's not nice to say outliers, but I don't know how else to describe it here. You're kind of looking for outliers. You're saying who's doing a large volume of services that maybe needs just to talk to kind of see what their approach is, because it seems like they're triggering a high % on some of these different results. And so this is kind of your landing spot to say, what is the most actionable place I should start for who I should talk to within my system? Go to the next slide. We also provide resources to say, if you're going to talk to an individual physician and you want to just show them their results, we got feedback that's like, give me something I can just print and give to them. Like, so something I'll go for an individual practitioner. I can print this off and I can give it to them with very structured language that's been heavily reviewed and edited, and just shows their results compared to some major benchmarks. So we always have done that from the beginning too. If we go to the next slide. And then then kind of the follow-up requests and customizations go from there, right? So then we would get asked to say, hey, that's great, you're telling me that I'm doing potentially too many of these low value pre-op labs, but can you tell me what surgeries they're for or what people are billing these under? Because that would be really helpful for me to go into my EMR or my data warehouse to see what's going on, right? Because they would get these requests from the physicians. So then we started giving more granular reports even down to the code level to say, this is within that measure result that you have, this is how that spreads out into something for the actual codes for you to go back and look at your own data. Go to the next slide. And then as the program matured over time, a lot more focus was on trends, right? Particularly given that we're saying we're going to target a 25% reduction overall with the program. And so that's where we started putting out these trend reports, say from the beginning to the end, what's your volume? What's your percent? Like, how are you tracking compared to what we're trying to do for yourself and compared to your peers? And if we go to the next slide, but each of these measures, it's just it's like the intervention, right? It's 9 measures, but none of them are really the same in terms of what you might do. So for instance, pre-op labs, this data is a little bit old, but I don't expect it's changed a whole heck of a lot. You've got this thing where you've got a certain number of physicians that are really high performing, like they're not doing very many low value services, but the vast majority just fall in a straight line, right? Like obviously the common practice is that everyone's sort of hitting this point, but then we've got a few that we got to learn from the other end to say, what are you doing so well that's giving you this kind of tail here where you're getting these low value, these low results for your index, versus if you go to the next slide for a different measure. For eye disease, that's one where the baseline practice is that people are doing a good job, but you've got one poll of physicians that look a lot different than everybody else. And so it's like, how do we get them back to the standard practice of everybody else? And so these distributions can be all over the place and might tailor for an individual system what they want to do, depending on the measure that they are most interested in. Because, yeah, what happens is that most systems are not trying to do 9 things at one time. They'll choose 1 or 2 and work on that for a while, see what works, and then maybe move on to another, or particularly try to specialize in a few. So if we go to the next slide. Now, one thing I want to highlight that Tim mentioned that it wasn't super highlighted in the slide, and I wouldn't expect you to think much of it, but it's been a huge deal for us, is the waste calculator version. Okay. So when we started this program, it was version 7. And we said our original plan was we're not going to change the version over the course of this intervention because the results could change, right? You introduce a new version, there could be a lot of big changes. We want to keep things consistent. Let's stay with version 7. Okay. And we did that for a long time. And then what we found out is that when we talked to different practices and systems on what they wanted and how they thought about the measures and what they thought the index represented, was like, oh no, that we actually need to go to version 8 for you to be able to do that. And so we made, we'll see whether it was wise or unwise, but we decided like in this calendar year at the end of the intervention to be like, let's change to version 8. So this slide highlight, and now the good news, like I said with Tim, is that you all are already doing things in version 8, right? But for this baseline lab study, when you add in those optimal events, like first of all, this measure, like the numerator got smaller, and then the denominator got way larger because of these optimal events, which is absolutely the right thing to do because you're giving physicians, providers credit for all the good things they're doing, not just trying to dissect this subset that are potentially an issue. So this is, I think, way fairer and way more in line with what people are expecting. And I don't know if you could read this, but the results we have in version 7 was like 80% versus version 8, it's like 8 or 9%, right? And a lot of the trends look similar, but the scale is way different. And so we certainly would not have planned that if we knew from the beginning, like, I don't know, we probably would have adjusted differently, but that's real life, right? We're having to go through this multi-year program. You try to do the best that you can. And so we're switching over to version 8 and are going to run with that to the end of the program. But I feel like it has been well received because everyone knows we're just trying to give them the best, most actionable, fairest data that we can. So if we go to the next slide. And I just want to highlight, I mean, you saw a great presentation for Tim on the awesome results you all are doing. Like I feel like it's very well prepared, very nuanced. Like that's 100 times better than the reporting we were doing in Virginia when we first started. But it's really started to catch on. I mean, there are several other states that are doing this. We were part of this. I forget what year this got released from VBID, but Colorado, Virginia, Maine, Washington, we all participated in this analysis and study with VBID a couple of years ago. And if you go to the next slide, kind of what that showed is that this is not a Virginia problem, or Washington's been doing this for a long time too. It's not a Washington problem. The results got to look similar for everywhere. And so this, if we're doing an intervention in Virginia, we should probably do an intervention in some of these other places too to try to get these reductions in this ROI for our different constituents. And so it's been awesome to see what the different states that have been involved in this report have put out since then. I mean, that analysis has really come a long way, and more states are. I think that this analysis is trying to be done again, and there might be twice as many states. I mean, it's definitely been caught on. So Colorado has certainly been an early adopter of this as well, and has a lot of really awesome experience that could be applied to an intervention. If we go to the next slide. So just reflecting on this a bit to wrap up. Now, there is no way I can talk about this without mentioning COVID-19. Now, of the impacts of COVID-19, obviously reporting on low value care is not in the top 500 of importance, but within our world of trying to do this intervention, we had to put it on pause. I mean, it's just like you're trying to reduce potentially low value services and no one is having any elective services at all. It's there's not a whole lot to evaluate. So we actually to VCHI's credit, they were able to talk to our own foundation to do a 1-year extension and say, we got to just throw away a certain period of time here. But it is going to make things very difficult to analyze on the back end and muddies the water a bit. But I still think we're going to get some good results, and we've got a lot of good things that have come up since then. But it's just an extra nuance that no one would have ever expected. Like, so when you do something multi-year, you just got to run with kind of roll with the punches here. As everybody knows, with claims, it's not real time, right? And sometimes that doesn't matter, and other times people really care about that. If data is 6 months or a year old. And I feel like the beginning of the program, it's like it's okay, we'll get it. But it gets a little bit tougher when you got COVID. Like, with Tim showing, it's like, well, you need to show 2019 results because 2020 is so messy. Like, you have lag data to begin with, and then when you throw out, you need to have this period you throw out, it can make your data really like lagged up because you're just trying to be a responsible reporter of it. But it does make things more complicated. I already talked at length about the waste calculator version. I don't expect that to be an issue for you all, but it just was a big change that we're still kind of making the most of as part of our program. Another weird thing too is like, you got to be really careful when attributing results back. Like, if you're reporting and saying, physician X or physician Y, we think these are the services you may be that were discretionary on whether they needed to be provided to the patient. Like, you got to be careful at making that determination. And so the methodology is naturally pretty conservative. And so a lot of results don't get attributed to a physician, they get attributed to a facility or to an institutional provider. And so since we're working with these systems at the system level, it's always a consideration of, for it to be truly actionable, it needs to tie back to the individual provider. But we've got this huge bucket of system-wide results. Like, should we include that or not? And the short answer is some systems want you to include it and some don't. But a great thing going through this process is that it is awesome to try to validate. Like, it's one thing to report on low value care or report with claims, but when you actually go do an intervention, it's like someone's going to be very much beating up these results and be looking for reasons why they think maybe there could be some problems. So it makes you up your game from a quality perspective. And it's just good. I mean, it's a good practice to be in, to really make you accountable for the data of like, are you really sure? And you feel really good about reporting these results out because the stakes are much higher. And then I think my next slide is probably my last. I've reiterated some of these different things. I mean, nothing has generated more interest, point blank, from the APCD in Virginia than reporting on low value care. It's absolutely been our premier reporting series, no doubt. It really takes it and facilitates moving from just kind of primarily being a research or policy support to saying, how do we use claims to support clinical decision making? And there's all kinds of other different data sources for that. I'm not saying claims are the be all end all, but it just makes sure that we're stretching and using this data to the best that we can. And I mean, I truly do feel like, while APCDs are far from perfect, for doing this type of reporting, they're the best. It's awesome. Like, you've got this longitudinal data set on patients. It's multi-payer. It's okay if you don't have everything. We're trying to get generalizable rates to provide back to physicians. Like, we can see a variety of different perspectives. It's really flexible, Swiss Army knife. And so APCDs, I feel, are just tailor-made to support some of these different things. And that's certainly been our experience in Virginia. So I think with that, Carrie, it's just a wrap-up slide. So again, I really appreciate the time and the podium to get to talk about the work that we've been doing, and really excited to see what work happens in Colorado and beyond as we continue to mature together and grow together in tackling low value care.
Well, thank you so much, Kyle. And we so appreciate you being here and sharing your journey. You've been at this for a while, and it's exciting to see that you guys have actually been using it to do some interventions. And I'd love for Colorado to take that next step too. So hopefully this gets people in Colorado excited about the work that you've been doing and getting the juices flowing of what we could do here. So we do have some time for questions, and we did have a couple of questions that have come in the chat. Make sure if you do have questions to go ahead and type those in. We did answer a question regarding what in Colorado the allowed amounts were, and we do a conservative methodology, which might be a little bit different than what Virginia does. I know when we did that like multi-state analysis, we made the decision to go to the claim line level and to pull out just what was designated as the plan paid and member liability costs for that particular service. So I know some other states look at the whole episode that happened that one day and may not have just pulled out the low value care piece, but included costs. So sometimes when you're looking at different states, that there might be higher costs in other states. Ours are a pretty conservative look at the actual low value care instance. Just a little caveat. But then John Bartholomew wanted to make the point of Medicaid. Our Medicaid reported costs don't include supplemental payments because those come outside of the claims as a supplemental file that we include in like our cost of care information that we provide. But from a low value care cost estimate, we don't have those supplemental payments tied back to those individual low value care. So what we're reporting on Medicaid is underrepresentative of what might actually have gotten paid if there were supplemental payments that came in outside of those claims. So thank you, John, for clarifying that.
Carrie, can I just say something on that too, just to further validate what you're saying?
Sure.
So I completely agree that doing the, if to start out, you should do the claim line information. We didn't do that because we didn't know any better. And it overstates it for sure. I mean, like, since that number I showed back from like 2018, like, you're right, there are things in there that I don't think should be included. Over time, we've seen it's like, it depends on the measure. Like, there are some that you should do line, there's some that you shouldn't, but if you have to choose one or the other, you should do line, because it's tough, right? When I know for us, like when we're reporting these big numbers, that's the scale people are used to. So all of a sudden you cut back the line and it's like, what the heck happened? It's kind of like version 7 to version 8. It's much better, I think, to start with that and be hyper conservative and say, hey, there might be a couple measures that we could maybe go to the case rate because that's actually more reflective, and work up to that. So I think the process you've taken with that is better, and learn from the mistake that we made at first of just going straight case rate for everything. So.
And that's a new thing that Milliman has in version 8. They have a recommendation for each measure on whether to use the line amount or the header amount.
Great, thank you. So we have a couple other questions. One is for you, Kyle, on what low value service did Virginia have the greatest dollar value decreasing?
That's a sensitive question right now. So again, I go back to the version change. So before version 8, low value labs, no doubt. Now there's a couple of things. First of all, case rate, which we just talked about, not knowing any better on that. And then 2 is that measure got changed quite a bit in version 8, like it got cut way back. So the short answer is, I don't know in version 8 exactly what it's going to be. I expect it'll be the same as you all, the opiate measure, because it's not, I doubt there are going to be such drastic regional differences that it's like, that's your number one and it's not our number one. I think it's just reporting it consistently. Like we were reporting it differently than you all were. So short answer is, I don't know. It was low value baseline labs for low risk surgery. It might still be, but I'm not sure. I know it's going to be a lot less when we go to tally up the results than it was before.
And then a part 2 on that is what were the efforts that seemed to work the best to get providers to change their habits around that? Do you have any insight on that?
So typically what we found works the best is we would set up a call between the system, like had a champion or a sponsor, right? And they might be in quality work for the system, or, and they would set up and then let practice leaders just beat the data to smithereens with us being on there. So we can be the punching bags with it and say, take that notes, whatever. And that puts the system liaison in the middle. It's not like they're coming at the physician. It's kind of triangulates the relationship. And then I guess what we found is that if you don't come in pushing something and say, hey, we're not judging you, look at these results and just let us know what you think. Absolutely, you will have holes poked in certain things. But then over time, it's like, well, you build a certain amount of credibility and trust by saying you can beat up what you want, but then just tell me what you think is valid too with it. And those are the best insights I feel like you get from it. So don't be judgmental. Always go in assuming like it could be something weird with the data. It could be something going on in the back end payment office. Always get the benefit of the doubt to say, these are some results. Tell us what you think. That always works the best. Anytime you're coming in with an agenda to say, oh, you're not performing up to your peers. It's terrible.
Right. I think when I actually talked to, it wasn't you, Kyle, a couple of years ago when you had first started your project, I was talking to one of your colleagues, and they said when they went to actually one of your main champions, he was shocked at his own data because he had no idea. He was like, I'm not doing any of these low value care services. But then when he looked at like the lab tests, vitamin D was automatically wrapped into that health system lab test without him even realizing it. So it's not necessarily things that they're doing on purpose. They're obviously all practitioners are doing the best that they can and doing what they think is best, but sometimes you're not even aware that it's happening outside of your purview. So kind of interesting.
And another thing so don't call it waste. Like I learned that quickly too. It was one of the worst presentations I've ever given in my life was when we presented some of the initial results. And I was trying to waste this, waste that. I mean, I was worried I was gonna get like a shoe thrown at me. I mean, I totally bombed that presentation because it just was so off-putting. Again, you're coming in with a judgmental sentiment that says you're wasting something, and that just puts people off immediately. And so just the optic of it is no coincidence that was pivoted to low value care, because it just the sentiment that it sends is very different. And so the language you use is very important with it. That we learned that very quickly.
Yes, very good point. We also have a question about whether low value care initiatives have been used to entice the voluntary ERISA self-insured employer participation. I know we have used that, and as Tim mentioned, we have a specific employer standard report developed so that if we can run a particular employer's data so that they can see these are the low value care services that are happening with my employees. So you can do not only employee education, but if you wanted to work with providers in your network to try and reduce low value care for your employees, you could use that data. We offer those for free, and it's difficult to get employers engaged. So we've been using it to try and entice voluntary participation, but there are a lot of other issues around voluntary participation that are challenging outside of what this call can address right now. But Kyle, I don't know if you have any.
No, you're not alone. I mean, I don't feel like it's moved the needle to get somebody in. Now, once their data's in, everyone wants it, because you're right. I mean, we do it for free as well. So like State of Virginia Employees Plan, it's been an awesome report that we've done that they really like to get, and they feel like it's really beneficial. So I feel like everyone's state employee plan should get information from it. But yeah, I must admit, I mean, I haven't had someone sign up just so they could get this report.
Yeah. It's an ongoing challenge. If anyone has a magic bullet to get voluntary ERISA participation, we would love to hear. We've been working a lot of different angles, and it's the ongoing challenge that we have. So let's see, I moved my screen, sorry. Couple other questions that have come in. How do we resolve the tension between low value care and revenue generation on the fee for service side? Brilliant question. Thoughts on that?
Tim, I'll defer to you if you want to say anything. I can chirp in. But
I mean, ultimately, the goal is low value care is care that is more harmful or costly to a patient than it is beneficial. So I think it should be a goal for everyone to try to reduce this. But I don't know, Kyle, if you have any other thoughts.
No, I mean, you want to make sure you're not going after one pocketbook. If you choose 9 measures, don't make them all for the same thing, right? It's kind of like, we maybe could all stand to reduce a few different things. So just make sure you diversify your approach. The second thing is that we've heard from some systems that it's like, it is true. Like if we're successful, we could lose a little bit of money. I mean, not an insane amount, right? We lose a little bit of money, but this is practice for value-based contracts, which we feel like are the future. And so it's a good way to pilot and try out some of these different things we think we're going to have to deploy in the future anyways that would actually save us money. And so we're willing to make a little bit of investment, make sure, especially because we're doing the right thing. And even beyond doing the right thing, it could also be in our own practical financial benefit, the way we expect things to be in the future.
Mm-hmm. Movement towards alternative payment models will help with that as well. So when people are on the hook for overall costs. But we're not there yet in Colorado or probably Virginia as well. Not as much alternative payment model percentages going on. That's another report we have on the same affordability dashboard, another plug for that. Jonathan was hoping that he could see the multi-state analysis. I don't know, Kyle, if you have that handy to put into the chat.
It's probably on the VBID website. I mean, either side should have it. I mean, maybe, I don't know, Tim, if you want to follow up for it. I mean,
I was going to say
everyone should have it. It's public.
Yeah, it's through VBID Health, so I would assume that they have it up on their website.
Yeah, I can't jump out of this to find it, but if anybody has it handy and wants to chat it in, that would be great. I think those are all of the questions that we have here today. Thank you guys so much for joining us again. Our presentations, our presenters were fabulous. Thank you so much. I just wanted to give a plug for our next webinar. It's on October 20th, same time on a Thursday. And we are going to be talking about advanced care planning. And we have some civic presenters that have been working in that space that will be talking to you about advanced care planning and our end of life project that we've been doing for several years now on costs at the end of life. So we would love to have you guys join. We are going to be sending out notification of that webinar here in the next several weeks. So be looking to sign up to join us. And if you guys have suggestions on other types, thank you, Tim, for finding that link. Any other topics that would be of interest, please feel free to let us know in the wrap up survey that you'll be getting. And we'd love to hear what you thought about this presentation as well. And this, thank you guys again so much. Thank you for everyone who participated, and to Kyle and to Tim, thank you. And to our behind the scenes folks, Spencer and stuff, who helped put all of these webinars on. Couldn't do it without you guys. So thanks again. And I hope everybody has a wonderful rest of your day. Bye-bye.
Thanks, everybody.